1 teaspoon of salt equals 2.3 grams or 2,300 milligrams of sodium. 1 gram of salt equals 17 milliequivalents of sodium. I can never remember this, so you've got to. Now, what are the recommendations? The UK and the US recommendations are, in general, to reduce your salt intake. That salt is sodium chloride, so the difference includes the chloride as well. Less than 6 grams of salt, or 2,300 or 2.3 grams of sodium, or 100 milliequivalents. These are just different measurements of the same thing. In the United Kingdom, the food industry has done a pretty good job of reducing their salt intake by 10%. And more recently, the advisory committees have tried to get Congress to enforce salt restriction in processed foods. So far, there's been no legislation about this, but the large companies, Kraft and Conagra, are voluntarily doing this now, starting to do this. And there was an announcement a few months ago that Doritos, the chips, are going to reduce their salt intake gradually over 5 years. And it's important that this is done gradually because our palates are used to the salt in the meals. So if you do it suddenly, it becomes unpalatable. Salt makes food taste good. And so if you do this gradually, it will help. And the potential benefit is thought to be by reducing the salt intake by 10%, it's 100,000 lives saved a year.
Question. Is there a salt substitute that is...
Good question. Salt substitute. Yes, there is salt substitute. Salt substitute is potassium chloride. So yeah, it's okay if your kidneys are fine, you don't have any potassium problems, but many patients think salt substitute is safe. It is generally safe unless you have advanced kidney disease, because then you can get potassium poisoning, especially if you're taking drugs like lisinopril and the other ACE inhibitors, ARBs. Probably the best salt substitute is avoidance, like garlic, lemon juice, spices, herbs, etc. Yes, back there.
What about that Himalayan pink salt that's supposed to be high in antioxidants?
Never heard of it, but tell us about it.
Act like regular salt in lots.
I have no idea, never heard of it. Himalayan salt?
It's sodium chloride.
Okay. It's kosher salt, I know about that. That I can tell you.
Well, someone said Japanese,
Well, the Japanese are very, very high salt intake.
It's not salt, but it tastes like salt.
I have no idea.
What do you know about monosodium glutamate?
I don't think that's an important cause of hypertension, and neither is other forms. It's thought, it's a good question, but it's thought that the combination of sodium and chloride is the key concept here. Things like sodium bicarbonate, sodium citrate probably don't do the same thing. So it's thought that the chloride ion, which is the negative part of the molecule, is just as important as the sodium. Yes, ma'am.
I was wondering if you could address the question. Both my parents have high blood pressure, grandmother's died of stroke.
Yeah.
But I have a second brother.
Yeah.
He's a Stanford, got an MBA. But he takes salt pills because he says he's an athlete. He swims or he plays tennis, so he has to eat salt pills afterward to replenish that.
Well, as long as his blood pressure is normal, he may be fine. If his blood pressure is high, then I think he's doing himself harm. So it's a balance. Certainly, you can lose vast amounts of salt in your sweat if you're losing, certain circumstances. You can lose 2, 3, 4 liters a day of sweat, which is half normal saline, which is half salt water. So you can lose vast amounts of sodium, which can be bad for you. Your blood pressure can drop. You can get, feel weak. But the answer is it depends. If he has his blood pressure checks and they're normal, I think he's probably okay. Where are we? Resistant hypertension. So there is this condition called resistant hypertension. What is that? Uncontrolled hypertension, greater than the guidelines that I gave you, despite taking 3 or more drugs of a different class. So beta blocker, calcium blocker, RAS blocker. One of them should be a diuretic. That's the definition of resistant hypertension. Now, how important is salt restriction in these folks? And they did this very good study at the NIH recently, Pimenta, and they found that patients with resistant hypertension who went on a low-salt diet could lower their blood pressure by 23/9. So the effect is vastly different in patients with resistant hypertension. So these people are much more salt sensitive. How do we measure how much salt you're ingesting? I'm going to talk a bit more about this, what your concept of how much salt you're eating. How do we measure it? It's actually quite simple. The best way to measure this, in terms of our body function and salt, what goes in, goes out. So other than sweat, the vast majority of the salt that you eat comes out in your urine. So if you measure the salt excretion through the kidneys, that's telling you how much salt you're eating. And generally we can do that with a 24-hour urine collection or a ratio of sodium and creatinine in the urine. People may think that they're on a low-salt diet, and the truth of the matter is that a lot of folks are actually not on a low-salt diet. It turns out that only 15% of your salt intake is derived from your own cooking. 85% is derived from processed foods, eating out of restaurants. So by not having a little salt on the table does not mean you're on a low-salt diet by any means. And so this is how we measure the urine sodium. And the dietitians have come up with various studies, and have come to various authorities have come up with this, that the need to achieve a low-salt diet in order to overcome resistance to medication may need the help from a dietitian. And perhaps our dietitian can comment on this after the talk, but it is very, very, salt is pervasive everywhere. You have no idea where the salt is coming from. Generally, if you eat out and it tastes good, it's packed with salt. Can salt damage the kidneys? I think we're moving. Are we okay with time, or should I rush this along? You're okay? The Nurses' Health Study, can salt damage kidneys? The answer is maybe, besides causing hypertension. Again, I don't know why they pick on nurses all the time, but this was done in 3,200 nurses over 11 years, and 11.5% experienced a 30+% decline in kidney function. Mean age of the study was 67 years. And what they found was that the highest salt intake was associated with the biggest decline in kidney function. People have seen this in experimental animal studies as well. And in the same study, they found the same risk if you had more than 2 artificial sweetened sodas a day. So, this takes on to another nutritional topic, high fructose corn syrup. Very common around. And this has, the increased intake has mirrored the increase in hypertension in the United States over the past couple of decades. They looked at 4,500 adults with no prior hypertension. They took a careful diet history, and HFCS is in fruit juices, baked goods, soft drinks, candy. Anything else, nutritionists there?
Sorry.
Okay. Any other sources of high fructose corn syrup other than fruit juice, baked goods, soft drinks, candy?
Bread and salad dressing.
Salad dressing?
And bread.
Bread?
Fritos.
Okay, very common. And they found that the mean intake of this was 74 grams, which is about 2.5 sugary drinks a day. If you drank or ate more than 74 grams, the blood pressure rises the more you ingest. And why does it do it? It's thought that
Is there any evidence that fructose is any different than sucrose in this?
probably not. This topic has been thought up. It's thought up. Both of them are molecules of glucose stuck together, glucose molecules stuck together. It's thought that fructose suppresses natural vasodilators, again the nitric oxide stuff. And in animals they retain more salt. Now this topic of alcohol, sorry.
Does fruit affect
No.
the sugar in fruit?
No. Fruit, that, in fact, that's a recommended part of your DASH diet. So alcohol. I don't know if any of you saw the newspaper the last couple of days. Heavy inebriates let's put it away. Heavy drinkers live longer than teetotalers. Are you aware of that?
No.
And modest drinkers do even better. Okay, so it's been known for years that a modest intake of alcohol is associated with a reduction in cardiac mortality and heart attacks. No question about it. And but if you have more than 2 drinks a day, there's a 1.2 to 2-fold increased incidence of hypertension, and more than 5 a day associated with severe hypertension. And this is reversible. You stop drinking, the blood pressure goes back to normal. Why is alcohol beneficial to your cardiovascular health? No one knows. But these are, and it could be cultural things such as in France, where people eat slower and are more relaxed and they have their long lunches and don't work that hard and retire when they're 62.
60.
60. I don't want, yeah, that's
They're striking again.
They're striking because they want to change to 62. That's why they live longer. But in any event, these are some sort of hocus-pocus theories of why alcohol may be beneficial. But there was an alcohol advisory in 2001, 1 to 2 drinks a day associated with a reduced incidence of cardiovascular disease. No one knows why. Large-scale studies needed. No current recommendation to use alcohol as a cardiac protective treatment. But for what it's worth, have a glass of wine a day. 2 if you're a guy. Any idea what the score is, by the way?
2-0 Giants.
Hey!
Bottom of the 4th.
Bottom of the 4th. Thank you. So this new study that I just mentioned. Okay, alcohol and kidney function. Just very briefly, the bottom line here is that there's an increased incidence of protein if you drink heavily. There is a 40% reduction in chronic kidney disease as measured by the GFR in heavy drinkers. Why is that? The real reason is that these people have muscle wasting, liver damage, and that's where creatinine comes from. Creatinine comes from muscle. So the less muscle you have, the less creatinine you make, the lower your creatinine level is, and seemingly the better your GFR is. So it's really not a real benefit. It's that there's just less creatinine production. So we're going to end off now. Conclusion. Hypertension is not only an individual but also a societal, budgetary and public health problem starting in childhood. Lifestyle choices sets the stage. With diabetes, hypertension is the commonest cause of chronic and end-stage kidney disease. Modified behavior by the food industry and marketing is needed. A nutritionist can play a very important role in helping people at risk with their salt intake. And if there are any questions left over, I'm here. Thank you. Yes, sir.
Blood thinners such as
Coumadin.
ever used to control blood pressure?
No, blood.
Please repeat the question.
Yeah, well, the question was, do blood thinners, and there are different forms of blood thinners, aspirin, Coumadin, Plavix, are they ever used to treat high blood pressure? The answer is no, they have no effect on blood pressure. They are used mainly in patients with chronic atrial fibrillation, people with artificial mechanical heart valve, people who have recurrent clots, deep vein thrombosis, but they have no beneficial effect on high blood pressure.
Is there any studies on marijuana use in hypertension?
I don't believe that there are any, not that I know of. From personal experience, when I was younger, I always used to have that heart pounding feeling after I've had a joint. I don't know if any of you have experienced this. I don't think so.
Is that bad?
It will transiently raise your, as does alcohol. The mechanism of alcohol causing your blood pressure to go up is probably that it causes your catecholamine system to stimulate, your adrenaline and system to start pounding. Probably the same thing happens with marijuana. I don't think marijuana is beneficial for hypertension. Certainly not used.
You don't project to 2 joints a day from that?
No. Yes, Mr. Igby.
But the problem with loss of weight, is it dietary or chemicals or drugs assist or aid in gaining the proper weight, but the person is of low weight?
Well, some people's natural constitution is to be small-statured. I think if there's a big drop in weight, the thing is to find out why, take a new diet history. But there are some medications that can help weight gain. We've used various appetite-stimulating drugs, like an example would be a drug like Remeron, which is an antidepressant, which has a side effect of weight gain. Somebody asked about marijuana. That makes you get the munchies. It makes you want to eat a lot. Many of the antidepressants can cause weight gain, but it depends what the cause is. And then there are various nutritional supplements with lots of calories that help that.
What would one do to seek a definitive answer on something like this? Is there a specialist, and which specialist?
I think you generally want to start with your regular physician. If there's thought to be an endocrine cause, an endocrinologist maybe. But sometimes it just takes a good nutritional consult with a diet history to see how many calories the patients are ingesting and take it from there. Okay. Jeff.
Right. In terms of changing your salt intake to reduce it or increase it, over what period of time are the effects reversible?
You mean how long after salt restriction does your blood pressure come down, or how long does
or whatever other body effects there are?
It can take weeks for this to be seen. I can recall seeing a patient recently who, again, a patient who is a nursing professional, actually works in our transplant clinic, who came to see me with uncontrolled hypertension. And I did the 24-hour urine, and it showed that she was actually ingesting at least twice more the maximum sodium intake, thinking she was on a low-salt diet. I think it took about 2 weeks for her blood pressure to come down to normal. It can take a couple of weeks. Good question. The question is there an optimal time to take your medications based on the variability of blood pressure during the day? In general, patients out of convenience people take their blood pressure meds in the morning, and again at bedtime, if it's twice a day dosing. Sometimes we have to adjust the medication. For example, if the highest reading is first thing in the morning when the patient wakes up, and that's the danger time, we'll add in a medication before bed, so it'll have that effect by the morning. Sometimes you have to tailor it, but generally patients take their meds in the morning. A lot of these meds have 24-hour duration of action.
What about if your sodium is consistently too low?
When your serum sodium is...
Sodium.
Okay. Well, that is called hyponatremia, depending on how low it is. I mean, if it's just a couple of points below the normal range, usually it doesn't mean anything. Some people just have what we call a reset of the osmostat in the brain that controls your water intake. And the mechanism of controlling the sodium level is, or the fluid intake, is the thirst mechanism. So people get thirsty out of reason because the body is telling through the osmoreceptors in the brain to drink water because the sodium level's up a little. It's very, very sensitive to the amount of salt circulating, and sometimes it gets reset a little up or down. And like, for example, if your sodium is 136 and it's consistent, it's usually nothing to worry about. But if it's consistently lower, then there's a number of conditions that we think about. Low thyroid state, low adrenal function. Certain medications can predispose to it, like a diuretic, ACE inhibitor. And then there's a rare condition called SIADH, which is a condition where this vasopressin hormone from your brain is overactive and tells your kidney not to excrete water when it should, and it dilutes the sodium level. So there's an approach, it depends on the severity.
Thank you.
What level are you talking about?
I don't know. I mean, I just know it always says too low.
Too low, okay. Well,
I'll go back and look.
I think the one thing, just sensible thing would be to make sure your thyroid is functioning normally. You don't have a lot of thyroid. Yes, ma'am.
I wanted to clarify, did you say that salt substitute was not a good thing?
It is a good thing if your kidney function is normal and you have hypertension. It's an alternative to salt.
But not for
if you have problems with your potassium control, either because you're on a lot of medications that retain potassium, or your kidney function is at least stage 4, stage 3 level CKD, you need to be careful of salt substitute. Yes, ma'am.
Can caffeine, caffeine drinkers like coffee, I know you said drinks, can that also raise?
Caffeine can be a stimulant and can raise the blood pressure transiently. It's probably not an important cause of hypertension unless, of course, you're drinking vast quantities of caffeine. Caffeine also is a diuretic, actually, and it makes you urinate more. But large quantities of caffeine is a stimulant. Kids used to take it. I know my kids used to take Vivarin as kids when they went out partying. Anybody heard of Vivarin? Didn't know. I freaked out one night, Mike. Anyway, yeah, it can transcend, but it's not an important cause of hypertension. Yes, sir.
And what about Viagra?
Viagra, that's a good question. Viagra was developed originally as a blood pressure lowering drug, and it is an antihypertensive drug. But when the studies, when they were developing sildenafil, which is Viagra, were done, it wasn't that great a blood pressure lowering drug, but it had this other side effect. So it is a blood pressure lowering drug. And in fact, it's I'm not saying as you probably know, I don't want to make that assumption, but it turns out that the combination of sildenafil and the nitrates, nitroglycerin, can cause devastatingly low blood pressure. So yes, it is a blood pressure lowering drug. You mean are more and more people choosing not to do dialysis? Is that your question? Well, this is actually a very interesting and good question. I wouldn't poo-poo that question. It's become more evident, based on many studies, that people who are the extreme elderly, that's a term I'm not using, it's a term that's been used, people over the age of 80, if you look at outcome studies on patients over the age of 80 who go on dialysis, in general, after 12 months of dialysis, they are generally worse off than at the start of dialysis. And there's an initiative to discuss more seriously, the need to discuss more seriously the appropriateness and wisdom of putting yourself through dialysis if you have that.
Make it worse.
Is it worthwhile putting yourself through this? Generally speaking, people who are nursing home bound probably should not be put through dialysis. Now this kind of varies. Sometimes patients will say to you, I want everything done under whatever circumstances happen, either family or the patient themselves, and you're obliged to do your best for them. But it is becoming more and more apparent that it's our duty as healthcare providers to bring up this topic of not choosing to do dialysis or withdrawing from dialysis if the quality of life is not good. It's mandated that that option be given to the patient.
Could you say something more about the variability of blood pressure throughout the day in response to exercise, rest, stress, and so on? What ranges can be expected?
Okay, what are the normal when I'm talking about this blood pressure variability, I'm talking about blood pressure measured in the doctor's office. That's from that Ascot study. There is normal variability in your blood pressure during the daytime. Examples would be normally during sleep, for example, systolic readings of less than 80. In the morning, it's not unusual to get the readings of 130, 140, even 150. During exercise, vigorous exercise, or during sex for that matter, pressures can approach 160, 180 or higher. But generally speaking, within a very brief time, the blood pressures should come back to normal or even below normal, because with exercise, for example, your blood vessels open up, they dilate. So if you do a treadmill stress test, for example, while you're running on the treadmill, you can get blood pressure of 160, and that's a normal response to exercise. But within 5 to 10 minutes, stopping, it should come down or even below what you started at. So those are normal variations. And sometimes we actually do ambulatory blood pressure monitoring. Put a blood pressure machine on for 24 hours, and that gives a readout of what the blood pressure is. And that's quite a useful thing. We don't do enough of that, actually. Yes, ma'am. Lady at the back.
Yeah, thank you. You mentioned something about sodium chloride being the problem, and that brought up a question in my mind. I've been avoiding baking powder totally, which is sodium carbonate.
Sodium bicarbonate.
Bicarbonate. Well, could we use sodium bicarbonate to make some no salt of muffins or pancakes?
Well, if you want it to rise nicely, yes, you can. It tastes like hell. I don't know if you've tasted baking soda, but to provide the same flavor as salt, no, it won't do it.
I'm not talking about flavor. I'm talking chemistry. I've been avoiding baking powder totally because it's made out of sodium.
Yeah.
So do I need to continue to avoid it?
Probably not.
I'm salt sensitive.
Yeah. Well, you could try. I mean, if you have a muffin with a little sodium bicarbonate in, it's probably fine. And in terms of hypertension, it's well documented that it certainly doesn't have the same effect. It can a little bit, but not like salt, not like regular salt.
What about the sodium nitrate they use for curing yeast?
Probably the same.
Why don't we take one more question, then of course Dr. Gottheiner will be staying after to answer your questions one-on-one if we don't have an opportunity to have them asked right now.
Yeah, my blood pressure is normally about 115/60 something. But during dialysis, it tends to plummet down to about 80, sometimes below 65. Is that normal, or? And it leaves me asymptomatic. I don't get dizzy. I don't get cramping, or.
Well, a number of things happen during dialysis that generally can predispose to that. One is if there are large fluid gains, and you have to take off a lot of fluid, weight gain, taking off the fluid gain. What are your average weight gains?
Usually 2 kilos per treatment.
2 kilos. Well, that's not too much. So the blood pressure can drop during dialysis because you're taking fluid out of the vascular compartment, circulation. And your blood pressure has to be maintained by refilling of that vascular compartment where the fluid is removing. And if the fluid is removed at a more rapid rate that you can refill, your blood pressure is going to drop. In addition, other things are happening. The blood vessels tend to dilate, so that lowers your blood pressure. If you're diabetic, you could have something like what's called autonomic dysfunction, which is normally the heart pumps more powerfully during fluid removal. That can be a little impaired. So there are lots of reasons. In general, if you're not having any symptoms, you're probably okay. There are a few tricks that can be done to get around that if you want, like lowering the temperature of the fluid, having a shot of coffee, or taking a midodrine tablet before dialysis, and so on. But generally, if you have a good heart function and that's all that's happening, you're probably okay.